the management aspects of these patients. So we know the surface consists of the entire epithelial lining of the eye with the preocular tear film, and both these function as a single unit. Epithelium is non-keratinized. The goblet cells secrete the soluble mucins with the transmembrane mucins and glycoproteins, making the surface vegetable. And you have the tears, which is secreted by the meibomian, lacrimal, and the goblet cells on the surface. The other factors like the blinking and lid closure helps in further stabilizing the surface. And all these is under a delicate neuroanatomic control to give us a stable tear film. When there is any disruption in any of these factors, the eye goes in for ocular surface disorder and then finally failure of the surface. So the principles of management is basically addressing the tears, the inflammation, and the surface failure per se. And we have these speakers. We will have Dr. Vandana Jain giving us an overview of the disorders, and then about amniotic membrane transplantation. I'll be talking to you about a little bit about acute stage surgical management. Then we have Jatin speaking about the medical management. Vishram will be giving you an overview of the lamellar surgeries and the mucous membrane graft. Sayan is here, who will be talking about cell-based therapies in this condition. And finally, Dr. Srinivas K. Rao will be giving us an overview of the keratoprocesses, and then we can go in for discussions. Thank you.
Right now would be to just give an overview about the ocular surface diseases. Vinay has already spoken about what is ocular surface. Now, whenever there are a series of pathological events which actually can lead to disturbance and lead to various kinds of ocular surface diseases, in that there is a progressive failure of the tear film, which in turn causes subclinical inflammation and the epithelium starts undergoing changes. This is at the heart of most of the ocular surface diseases. Now, when we talk about the ocular surface failure, it is primarily of two kinds, and this is something we decide on the basis of the resultant epithelial phenotype. In dry eye related disorders, there is a change of the epithelium from non-keratinized to keratinized, which we also call as Pons metaplasia. And the second group of failure, the ocular surface failure disorders, include those diseases where there is a replacement of normal corneal epithelium with the invaded conjunctival epithelium, or what we also call as limbal stem cell deficiency. Now, dry eye, of course, is one of the most common causes of the ocular surface failure. We all know what it is. Just let's look at the various mechanisms which lead to it. In dry eye, there could be a decreased secretion, there could be delayed tear clearance, or altered tear composition. Now, all of these things can lead to an unstable tear film, which in turn leads to ocular surface inflammation, and that is what is at the heart of the dry eye disorders. One of the commonest causes of dry eye in India is meibomian gland dysfunction, which we all know is a disease which mostly affects older individuals and is fairly common in Asians. Now, when we talk about meibomian gland disorder, then the various pathogenic mechanisms work to cause meibomian gland dysfunction, and one of the commonest key events in meibomian gland dysfunction is the hyperkeratinization of the terminal duct lining, which in turn causes obstruction of these glands and is also responsible for not just the altered secretion but also reduced secretion, and in turn causes surface inflammation and creates a vicious cycle, which also then in further stages causes aqueous tear deficiency. Now, with the meibomian gland dysfunction workshop, numerous the grading system has been given, which has actually made the management of meibomian gland dysfunction very easy. Now, this grading is based on the amount of secretion, that is how many glands we can get the secretion from, what is the consistency of these secretions, what is the symptomatology of the patient, if there is any corneal staining. Based on that, we divide the disease into various stages, and then we can treat accordingly. Now, there are other fairly common causes of tear film disorders, such as conjunctivochalasis. Again, this is one of those causes which is a little underdiagnosed as a cause of ocular surface disorder. Now, conjunctivochalasis, besides the fact that it disrupts the normal tear meniscus, it can also cause delayed tear clearance, which in turn causes surface inflammation. SLK or superior limbic keratoconjunctivitis is a blink-related microtrauma. It's a group of disorders. Now, even SLK is something which can be associated with dry eye and can also lead to surface inflammation and contribute to the ocular surface, localized ocular surface failure. Now, vernal keratoconjunctivitis or other allergic group of disorders, they are somewhere in between the dry eye-related disorders and the limbal stem cell deficiency, and they can progress from one stage to another. Now, VKC, of course, has various forms such as tarsal, limbal, and the mixed forms, which is more common in Indians. VKC in around 5% of patients can actually progress to various other stages such as corneal involvement in terms of shield ulcer, etc., and leading to astigmatism and also keratoconus in some cases. But what is it I want to focus on is VKC leading to limbal stem cell deficiency, which can happen in around 0.2% of cases, as was studied at LVP as well. Now, the reason why VKC can also lead to limbal stem cell deficiency is because of two mechanisms. One is that there is a poor stromal support which can cause chronic limbal inflammation and cause damage to limbal stem cells. Secondly, there is a direct damage to stem cells due to the toxic products which are released in this allergy. And per se, limbal stem cell deficiency, as we all understand, is a group of disorders where there is a conjunctivalization of cornea. There is neovascularization, chronic inflammation of the surface, and repeat epithelial defects. Again, all these disorders which cause limbal stem cell deficiency can either cause direct damage to the stem cells, or they can cause a poor stromal support which lead to damage to the limbal stem cells. When it comes to the management options, it depends on whether it is unilateral, bilateral, how severe it is, and if it is visually significant, then we can choose one of these treatment modalities which will be spoken about later during the talks. When we are treating patients with limbal stem cell deficiency by transplantation, we always make sure that surface at least gets a little bit more stable in terms of the lid abnormalities, ocular surface inflammation, dry eye, etc. And we also like to screen the patient to rule out any systemic condition whereby we cannot give immunosuppression if required to the patient. And these are some of the examples where when the ocular surface there is a failure, which is again a mixed kind of failure, they can be managed with limbal stem cell transplantation and later on with cornea transplantation. So this is how, basically, to conclude this talk, ocular surface as a whole and its individual components are in highly dynamic state. When adaptive responses are not able to cope with the aggression, a persistent dysfunction may develop. The process is not even, characterized by cycles of worsening and improvement. Therapeutic approach to this condition cannot be unique and stable all along. I thank you all for your patient hearing.
Thank you, Dr. Vandana. Now there is a slight change in the order. Dr. Sain will be giving his talk now, since he has to leave early.
Vinay asked me, first of all, thank you Vinay for making me a part of this IC. It's great to be presenting in the same forum as you after a long time. So, he asked me to talk about cell-based therapy for ocular surface disease. And as soon as the PowerPoint comes up, we'll get going. So as you all know, a healthy ocular surface, to have a healthy ocular surface, you need a healthy limbus. And the reason for this is that the corneal epithelium is maintained in a healthy state by the epithelial stem cells which are located in the palisades at the limbus. And the palisades continuously supply epithelial cells, which go over the cornea, replenish it, because you're constantly losing epithelial cells from the corneal surface, like any other surface epithelium, because of desiccation, because of exposure to the environment. And limbal stem cells, which are located deep down in the limbal palisades, to make sure that this continuous supply is maintained and the corneal epithelium remains smooth and uniform, and so that you have good vision. But any damage to the limbus results in a clinical condition which is called limbal stem cell deficiency, and this is typical epithelium on the surface, which is vascularization, the surface is not healthy, it keeps breaking down, and there's loss of vision. Now, depending on the extent of involvement, it can be unilateral or bilateral, can be total or partial. Total is when the entire limbus is affected. Partial or subtotal is when some parts of the limbus is affected and some parts are spared. Now, limbal stem cell deficiency, again, another important aspect to it is whether the surface is wet or dry. So typically in ocular burns, you will see a surface which has some luster, which has a little bit of tearing. Sometimes there's good tearing, or you can have a dry surface like in Stevens-Johnson syndrome or toxic epidermal necrolysis sequelae, where you have a completely dry surface, and you can find that the corneal epithelium almost looks like skin, which is known as doubleization. So, instead of conjunctivization, or at least you have some wet epithelium on the cornea, you have dry skin-like epithelium. Now, the treatment algorithm that we follow for ocular surface disease due to limbal stem cell deficiency goes somewhat like this. So if you have a patient with a unilateral corneal blindness due to limbal stem cell deficiency, then we look for whether the patient has visual potential or not. And if the patient has visual potential, we look at other factors. Like I just told you, you have to look, one of the important prognostic markers is whether the surface is dry or wet. And you also have to look at the lid, so if the lid function is good or not. So if there are any lid problems, trichiasis, entropion, lid notching, exposure, those need to be addressed first. So that the surface is dry, or if the patient does not have any visual potential and it's a unilateral problem, we usually don't do anything for those patients. However, if the surface is wet, then we can try a limbal stem cell transplantation. Usually in these cases, it's autologous, so you can take the limbus from the unaffected eye. And if the surface is dry or the patients don't have visual potential, as I just told, we don't usually do any surgical procedures for that. So you give them some kind of a cosmetic correction. However, if the patient has bilateral problem or it's the only eye of the patient, you don't have autologous source of the limbal tissue, and usually for these patients we do a keratoprosthesis. Again, if there is visual potential, it's bilateral and dry, you have other keratoprosthesis that you can try for these patients. And if there is no visual potential, of course, these are not eyes that you should play with, because the risk of complications is very high. So, in limbal stem cell transplantation, fortunately, although limbal stem cell deficiency is a very rare but severe form of corneal blindness, it can be addressed. You can take healthy limbus from a donor eye, if possible from the healthy fellow eye, because then it's autologous, doesn't have the risk of immunological rejection. You don't have to immunosuppress the patient. And you can transplant it after removing the pathological pannus from the affected eye. And the conventional technique, as originally described by Kenny and Singh, is where you take a large lenticule which contains peripheral cornea, limbus, and conjunctiva, and you can take 3 clock hours or more and transplant it on the ocular surface. Or you can take a small bit of limbus and grow it in the lab and expand the cells on a suitable substrate, which can be fibrin or can be an amniotic membrane, and then transplant it back on the surface. You transplant a sheet of cells instead of just the limbus, and this works just as well. So both these procedures are known to be very effective in treating ocular surface disease due to limbal stem cell deficiency. Now the nomenclature is a little confusing. It depends on where you take the donor. So whether the donor is living or cadaveric. So you can have, if the other eye is healthy, then usually you take it from the other eye where it is autologous. So this technique is called congenital limbal autografting. If you take it from a living donor, then it's an allogenic transplant. This can be living related or unrelated. So it can be somebody who's related to the patient or somebody who's unrelated. It can be HLA matched, it can be HLA unmatched. Depends on whether you do HLA matching. Usually, very rarely, because HLA matching is very expensive, is that done. So mostly it's living related, may or may not be HLA matched. And if you take it from a corneoscleral rim where it's cadaveric, then it's called a keratolimbal allografting, so KLAL. So usually you take 2 clock hours, which are around 3, we take 2 lenticles, which are around 3 clock hours in length. and that is transplanted on the surface on the recipient eye. So these are two different techniques of doing the same procedure. One in which we started the dissection from the conjunctival side, and the other where we started the dissection from the corneal side. It's usually seen that if you do the dissection from the conjunctival side, the chances of having problems in the recipient eye are less. So essentially that you take the whole large lenticule and you put it on the eye, and you can either suture it or stick it with glue. Usually people prefer suturing. Conventional LSCT has been around for many decades now, and it's known to be pretty efficacious in treating ocular surface disease due to LSCT. But because you put the lenticules in the periphery, it takes time for the cornea to epithelize because the cells growing from the limbus inside. And sometimes there might be problems. You might end up with persistent visibility defects, etc. The major problem with the conventional technique is that not everybody is as skilled as, for example, Dr. Rao, who described his technique in this study in 1999. And you can end up causing damage to the donor eye because you're taking so much of tissue from there. And if you don't have too much experience in dealing with ocular surface diseases, then you can end up damaging donor eye, like in this series. You can see this is the transplanted eye, which has had recurrence subsequently, which can happen. But you can see that in the donor eye also, because probably of deeper dissection or not using a particularly good technique, they've resulted in some amount of donor site conjunctivalization also. And this is very frequently reported, especially in people who are starting on doing this procedure. So you can work around this by doing a cultivated transplant where you take only a small amount, only one clock or so. There's hardly any chance that you're going to damage the limbus because you're taking so little tissue. There again, the nomenclature depends on where you take the donor tissue from. The Cornea Society says that we should call this procedure by these very complicated names, but we usually call it cultivated limbal epithelial transplantation or CLET. So here you take a biopsy, and that biopsy goes to the lab, then the cells are grown on an amniotic membrane, and then we transplant the amniotic membrane on the surface. So the amniotic membrane basically contains a ready-made layer of epithelial cells. At LUPI, we used a zero-free and feeder-free culture technique, which used autologous serum for culturing the cells, and this was relatively inexpensive as compared to using feeder cells and xenobiotics, which is routinely done in other centers. The benefits of cultivating the cells outside is obvious. It's very safe for the donor eye, and then you have a ready-made sheet of epithelium, so healing is faster and visual restoration is faster. And we published our results of this is about 10 years of experience of doing cultivated technique of transplantation. And as you can see, the outcomes are sometimes very satisfying. And we know that it's safe for the donor eyes, doesn't really cause any trouble. If you see how the donor side heals, you'll find that it actually heals from the corneal side to the conjunctival side. The defect in the corns is the last one. We have also found, interestingly, that that if your first transplant fails, which can happen in about 25 to 30% of patients, and if you go back and take another biopsy, cultivate the cells again and put them back onto the eye, you can treat 2/3 of cases of failure. So if you combine the efficacy of the first and the second procedure together, you can actually address about 90% of the patients with unilateral LSCD with wet surfaces. If you need to replace the cornea as well, it's probably better if you wait, do the limbal transplantation first and then do the keratoplasty, rather than doing them together, where the success rate is much lower. We also found, interestingly, that if you have a patient with unilateral limbal stem cell deficiency and which is partial, so you have 3 or 4 quadrants of the limbus is involved, you can take the donor limbal biopsy either from the same eye or from the opposite eye. It really doesn't matter. And then you can grow them and put them back. So whether you take the biopsy from the same eye or the opposite, very well with the Italian group, which is the other big group which does this procedure. We have found that it doesn't work as well in children as it does in adults. The success rates are much lower. Unfortunately, a lot of our patients are children. And there are other problems with the cultivated technique in the sense that it's costly. Not everybody can have a stem cell lab, and it's essentially very institution-based. So only a few institutions have this procedure available for them. So recently we have described this new technique where we do in vivo cultivation. So we don't take the biopsy and take it to a lab and grow it. It's grown in vivo, so you put the amniotic membrane just as you would do, but this amniotic membrane does not contain any cells. So you remove the panels and put the amniotic membrane into, and then you take the limbal biopsy that you've taken from the other eye, and you just cut it up into small pieces. This procedure is called simple limbal epithelial transplantation. Simple just to indicate because the procedure is much simpler compared to the previous techniques where you either had complicated stem cell labs or you had to take a larger biopsy, which in itself was complicated. And you just spread these pieces around, put one drop of glue on top of them, and that's pretty much the end of the procedure. And you put a bandage contact lens. You wait for the glue to gel, and you put a bandage contact lens on top. So initially we published the results in 2012. So these are pre-op photographs, and this is a time course showing how these eyes heal. And you can find at the end of 1 year, most of them will have a clear cornea and the surface will have epithelialized. One criticism of our initial publication was that it only dealt with patients who had good prognosis and not with complicated situations where patients had previous surgeries or had leg problems, etc. So we recently analyzed your results, and these are long-term results of 64 patients who had 1 year of follow-up. And you can see that unlike in the cultivated technique, the long-term outcomes in children and in adults is pretty similar in the simple limbal epithelial transplantation stem. We also found that in children who are less than 8 years of age, the visual recovery takes more time because they also need treatment for amblyopia. But over a period of time, the visual recovery is pretty comparable. So just to give you a few illustrative cases, each panel is a different, both eyes of different patients. So on top you have a child with a persistent epithelial defect, having undergone 2 amniotic membrane transplantations in the past. This is after SLED, stable surface. You can see it's not vascularized. There's a bit of scarring because of the PVD. The patient is 2080. In the middle panel, there's this young boy with very severe ocular surface damage, severe symblepharon coming onto the cornea. This is the same patient after 1 year wearing an RGP lens. It's 2060 corrected with RGP lens. And in the bottom panel, you have this very angry looking ocular surface, severe alkali burn, having undergone amniotic membrane once, and you can see this not really worked. And this is the same patient after SLED. You can see a little bit of peripheral vascularization, but here the cornea is clear, the patient is seeing and is maintaining the surface. Again, a few more complicated cases. The top panel previously failed cultivated limbal epithelial transplantation. Same patient after SLED, stable surface, clear cornea, a little bit amblyopic. Patient is 2060 uncorrected. In the middle panel, you had this patient who initially presented to me. The father of the child wanted the eye enucleated because it was so, ungainly, and the child could not close the eye. It's symptomatic, stopped going to school because of this, appearance of the eye. And we did a SLED for him, and this is the appearance of the eye after, and he's still 2 years out. He's still doing well. Again, in the bottom panel, patient with firecracker injury, failed cultivated transplant, same patient after SLED. So these are like exceptional outcomes. If you saw the patient, you wouldn't make out which eye had the injury or which eye had surgery. So SLED definitely has an advantage over the 2 previously described techniques. A, that you don't need an expensive stem cell lab, you have no risk of causing any damage to the donor eye, and that your success rates in children and adults are the same. So I think it's a definite improvement over the existing techniques. Is it easily replicable? We recently had this workshop and a meeting where people who are now doing SLED, not just in our institute but also in other places in India and outside India and other parts of the world, we had a meeting where people shared their experiences. How easy was it for them to do SLED? What were their outcomes? And it was really very encouraging, and we intend to have these meetings year after year so that and help people who want to start off with this procedure. So if any of you wanted to start doing SLED, you can just send us an email and we will send you all the material that you would need to start off. So I think chronic ocular surface disease due to LSCD is definitely treatable, and now we have more simpler techniques to address these problems. You just have to remember the cell-based therapy does not work in eyes that have lid problems, does not work in eyes that are dry. So that is one thing that you have to watch out for. And I think with the advancement in the technique of surgery and the simplification of the surgical technique, it has a potential for wider application. So that people who do not have sophisticated setups can even do this procedure for patients and treat their patients who have chronic ocular surface disease due to limbal cell surface. Thank you.
Thank you, sir. Any questions to Dr. Sai?
All right. Thanks, Vinay.
Right. Ongoing surface damage. Usually we are presented with chemical or thermal injuries and rarely acute Stevens-Johnson syndrome. So what is our aim? In this situation, our aim is mainly to control the inflammation to reduce the scarring response that can occur and to obtain as normal a healing response as possible. So the first step in chemical or thermal injury is to make sure that the nidus of infections, inflammation like this necrotic tissue and all are removed, and then go ahead with the further steps. I will not go into the medical management as the topic is specifically for the surgical steps. Various options available are amniotic membranes, tissue adhesives, tenonplasty, keratoplasties, and other lift procedures. I won't go into the details of amniotic membrane because the next talk is by Dr. Vandana Jain, who is going to give us in detail what amniotic membrane is about and what to do and what not to do with these things. But suffices to say that whether to do amniotic membrane or not is a decision which has to be taken based on the extent of injury. It is useful in healing. By itself it may not work and it may have to be repeated many times. And in cases like this where there is a perforation, you can use a multi-layered amniotic membrane. This is actually not a chemical injury, it's a post-keratoplastic perforation. That's gluing amniotic with fibrin glue, multiple layers. So this is a chemical injury with perforation which can undergo multi-layered amniotic membrane transplantation. So in Stevens-Johnson's, there are reports which have shown that amniotic membrane transplantation in early stage, less than 2 weeks, might help in controlling the inflammation and reducing the cicatricial changes. But beyond 2 weeks, is there a role? We still do not know. So the next procedure which is described in these cases is tissue adhesives, which is really helpful and really changed our management in these cases. It can be synthetic adhesive, and the most common one is a cyanide glue. What is most commonly available is the butyl one, though octyl ones are supposed to be better. It rapidly polymerizes on contact with the surface, especially if there is mild moisture, and care should be taken to apply a thin layer rather than the thick layer. Either can be done as his OP procedure in the slit lamp or in the theatre. Make sure the surface is deprived of the loose epithelium and other tissue debris. Apply it. There are 2 ways which I do. One is I take it in a 1 cc syringe with 30 gauge needle. You can put a small drop onto the surface, or you can just use the PVA sponges handle, the reverse, dip it in and just apply it there. It will give you a nice, even, thin glue on the surface, and put a bandage contact lens. So this is again actually a post-PK perforation. This is one of the most important steps, debriding the debris in and around the area of perforation, and then apply it. Again with AC reformation, and this is after glue removal after 3 months. Second picture. So the advantage of cyanoplate glue is it has got good bonding strength. It's longer retention. There is no risk of transmission of infection. Easy to use and cheap. Disadvantages: it's not very biocompatible, induces inflammation and vascularization, and has to be used on the surface and not inside. So biological is fibrin-based glue, and what is most commonly available is a pooled human plasma-derived tissue, and we have 2 products available in the market in India. One is the TCL from Baxter and Releaseal from Reliance. Other fibrin-based glues have been described and not yet available commercially. So basically it comes in 4 bottles. You have to mix the calcium chloride with the thrombin and the approtein with the TCL, which is basically the fibrin and other coagulation factors. This has to be incubated at 37 degrees. Usually the company gives the fibrinogen. And then just prior to, or these 2 components have to be mixed. Once these 2 are mixed, it forms a gel, and it has to be mixed on the surface. So this is a diploject given by the company at the time of, along with the kit. For ophthalmic use, it's better to use 2 separate syringes and put one drop of each onto the surface. So the advantage of fibrin glue is the addition of approtein, which has really helped in increasing the retention time of the glue on the surface to around 10 to 15 days. It's biodegradable, so it can be used under living tissue, has low inflammatory potential, and it has helped in kind of abolishing sutures in amniotics and reducing the number of sutures. can be used for amniotic membrane transplantation, lamellar corneal surgery, sclera, conjunctiva, and sutureless or reduces the suture as I mentioned before, which in turn reduces our surgical time, increases the patient comfort. So the disadvantage is the low tensile strength of this. So to compare, Sinoclate gives good support, cheap, easy to use, but induces inflammation, and care has to be taken that it shouldn't go into the eye or into the anterior chamber. While fibrin glue is an excellent adjunct, basically you cannot use the glue alone. It has got very low inflammatory potential, can be used, even if a little of the glue seeps into the anterior chamber, it doesn't cause any problems, but the problem is it's expensive, low tensile strength and difficult to prepare. Next procedure which is under-recognized and underutilized is the tenoplasty. It has got a very definitive role in scleral or limbal ischemia. The idea of this procedure is to bring the vascularization onto the area where there is no blood vessel, especially chemical and thermal injuries. And it has been shown by in this article by Geeta, and this is one of the cases which I know all of us who have dealt with this kind of things. We know whatever we do, whatever amniotic membrane, whatever we do, it's not going to survive, and eventually they will perforate or either go into icicle, and this is what the result they've got. So next tectonic procedure, which is of great importance, is the corneal transplants, which can be either lamellar or penetrating. In cases with stromal melt or small perforation, we can consider lamellar. The lamellae can be either sutured or glued. Glue is preferred now. So again, debrided, the area is debrided, and then the small lamellae, you can apply one component of the fibrin glue onto the lamellae and add it to the surface, or even both on the surface and immediately apply the lamellae. So this is the small perforation in Stevens-Johnson's. This is the corneal lamellae, and this is after the procedure. Similarly, this is a thermal injury which has produced a localized severe melt. So this is a D-shaped lamellar graft which has been glued, and it's like almost 2 weeks after the procedure. Again, in extensive melt, you'll have to think about full thickness transplant to stabilize the eye, and in these cases our idea is to save the eye rather than visual recovery, and once it stabilizes, based on how the eye heals, you have to decide further procedures for visual rehabilitation. Again, another important aspect to be looked at is the state of the adnex eye, especially the lids. Many of these cases, especially cases where there is extensive injury, can have lid defects, total loss of lids, and lid malposition. All these have to be corrected, and in many of them we will have to get our oculoplastic consultant into the loop to manage them. So, as I mentioned before, in these cases our aim is to control inflammation, reduce the scarring, and obtain as normal as healing as possible. And for this we may have to combine multiple procedures which may have to be used multiple times, and no reconstruction of the surface is attempted at this stage. Thank you. We'll go to the discussion at the end of the session now. Now I'll ask Dr. Vandana Jain to give a talk on amniotic membrane.
Just take you through some examples. Now, we all know that amniotic membrane has certain properties which are actually desirable when we are using amniotic membrane for various disorders. The anti-scarring, anti-angiogenic, and anti-inflammatory properties. They basically allow, if there is any normal tissue which is available, to repopulate the injured site before inflammation and scarring takes over. So basically what it allows is regeneration rather than repair. Now when we use amniotic membrane, there are various principles, and of course these principles, it's sort of a mix and match situation by the way we use it. It can be used just as a patch. The patch could be just a temporary patch, or sometimes we use it as a substitute of the stroma, and then we allow the epithelium to grow over it. And amniotic membrane, of course, is used for limbal stem cell cultivation in the labs as well. Now, when we talk about different conjunctival diseases where amniotic membrane has a role, the most common of which in everybody's practice is a pterygium surgery. where sometimes when we are dealing with recurrent regions, we take the help of amniotic membrane besides probably conjunctival autograft. Now, for example, in this patient, I did not take an autograft, but I just used the amniotic membrane and pulled the conjunctiva over it, and it actually worked pretty well. Now, when we talk about the corneal diseases and use of use of amniotic membrane in corneal diseases, then sometimes in cases of partial stem cell deficiency, we can actually use just amniotic membrane and see the response, because a lot of time when we reduce the surface inflammation, remove the pannus from the surface and put the amniotic membrane, then the remaining stem cells actually take over, and we actually don't need to do a limbal stem cell transplantation in some of these cases. Now, I'll just take you through some interesting examples, because this is a topic, as I said, is something that everybody has been doing for a very, very long time. This was a patient of fungal keratitis and also had ocular rosacea. Now, it is a challenging situation when you're dealing with fungal keratitis in patients who also have ocular surface inflammation due to various causes. Now, obviously, we could not use steroids. The patient, because of fungal keratitis, developed continued thinning. So we resorted to amniotic membrane transplantation again as a patch and continued with antifungals, and patient responded beautifully and healed with a small scar. This was another interesting patient who presented to us. He was on antivirals for more than 2 months, both oral as well as topical. When we looked at the surface was very dry, there were a lot of mucus, and there was a little shortening of the fornix, and the clinical evaluation gave us a suspicion of more of SJS-like picture. We took a detailed history and we found that patient actually is an HIV positive patient who was on nevirapine earlier and had developed a reaction to nevirapine, which was later discontinued by his treating physician. So basically, patient had developed an ocular SJS, which had led to this kind of persistent defects. So we performed amniotic membrane again as a patch, and within few weeks the patient healed completely. This was another patient of SJS who developed an E. coli keratitis, and in spite of all the efforts, the patient did not respond and again developed thinning. So we used amniotic membrane both as a filling, where we used the glue, because I did not want to remove the surface epithelium from the cornea. The second amniotic membrane, I used sutures, and again the surface healed. This was a patient of chemical burns who presented to us 3 months after the chemical burns with a persistent defect, which even after our treatment did not respond, and this was the stage where finally we decided to do an amniotic membrane again as a patch, and surface finally stabilized. This was a patient where we had done a penetrating keratoplasty. After a few months, he presented with a melt, which initially was a very small melt, but progressed circumferentially. Probably was a combination of tight sutures and other factors. We tried anticoagulative and mild steroids, lubricants, nothing worked. Did amniotic membrane transplantation, and the surface finally healed. Now, we all deal with the burns. Now, burns is actually one of the most common indications where we use amniotic membrane. But one of the things that we need to remember is that amniotic membrane is great for initial stabilization and reducing the inflammation of the surface, but it's not the be-all and end-all of managing these patients of acute chemical burns. Now, there have been numerous studies which have shown that amniotic membrane traps and induces apoptosis of inflammatory cells, and that is how it stabilizes the surface in cases of acute chemical burns. And also when we have to remove these pockets of line or whatever where we have to excise the conjunctiva, amniotic membrane works beautifully and reduces the chances of syphilis formation. We actually performed a study, it was part of my thesis long time ago, and we analyzed that in what all cases and how useful is amniotic membrane in these cases. And what we found was that for mild to moderate cases it works and by itself sufficient to stabilize the ocular surface. But more than moderate to severe cases, it just is an initial adjunct to future therapies, which can be in the form of limbal stem cell transplantation and other things. Naturally, when we deal with patients like this who have grade 4 chemical burns, in those cases, amniotic membrane once or twice or whatever number of times we do the amniotic membrane can only make the surface from further melting, but it still does lead to limbal stem cell deficiency and conjunctivalization and require future surgeries. Now, this was another interesting patient who was a case of BKC, developed a shield ulcer, and when we removed this plug and sent it for microbiology, we found that patient had actually fungus. Now, again, it was sort of a situation where you cannot give steroids to patients of a BKC with shield ulcer, and patient requires anti-inflammatory treatment. So after initial treatment, when patient did not respond, we did an amniotic membrane transplantation with antifungals and patient responded. And in spite of this big scar in the center, patient actually had a best corrected vision of 6/9. Conjunctival is a very common and very under-recognized entity, but some of these patients get really miserable because of the severe laxity of the conjunctiva and interference in their day-to-day activities like reading, etc. And these are the patients where we can selectively use, after the excision of this loose conjunctiva amniotic membrane, to stabilize the surface and improve the tear film of the patient. And so as in cases of SLK which do not respond to medical management, we can do an excision of the conjunctiva and put the amniotic membrane to stabilize the surface. However, again, amniotic membrane is not the end-all and be-all of all kind of ocular surface disorders. This patient was a case of aplastic anemia who presented to us with large scleral necrosis. Now, when you have such large scleral defects, then amniotic membrane by itself is not useful, such as cases like this, a necrotizing scleritis in a rheumatoid arthritis, or a patient who actually presented with a large scleral defect with almost the half of eye prolapsing out of that defect. In such cases, amniotic membrane by itself does not have enough structural rigidity to give support, or a patient of surgically induced necrotizing scleritis post-pterygium surgery where we had to do a scleral patch graft along with an amniotic membrane transplantation. Also, sometimes when we deal with alkali burns, where even though there is a grade 4 burn, but there is also some amount of ocular penetration, and in spite of whatever number of amniotic membrane transplantations we do, the patient's eye do turn tricycle in some cases. So I would conclude, amniotic membrane is extremely helpful tool in ocular surface surgery and has shown to prevent and reduce potentially disastrous damages to the surface. However, we need to remember its limitations while managing the ocular surface disorders. Thank you.
Thank you, Dr. Vandana. Now I'll request Dr. Jatin to give his talk.
Management that is available. The role of medical therapy in these cases often just supportive, and the most definitive role is of surgical therapy. I have no financial disclosure in any of the products that we mentioned during this presentation. We will be speaking about a few things about the acute stage management in terms of the medical management, the role of medical therapy in the chronic phase, and also the role of medical therapy in the end-stage disorders as to what, when, and how long should the medical therapy last. We're given a few case scenarios, such as in this case of a 20-year-old male who had a history of chemical injury a day back and was given saline wash. He was on therapy with lubrication, steroids, and cycloplegic. Compared to this, another scenario where a 31-year-old female who had a history of chemical injury 4 years back, which was left untreated in the acute phase, developed a right eye total limbal stem cell deficiency with lower limb secretory entropion and a semilefferon, and a left eye partial limbal stem cell deficiency. Going to another case scenario of a 13-year-old female with a history of antibiotic therapy given for fever, which was a week back. On day 3 of antibiotic therapy, she developed blisters all over the body, mouth, and redness of both eyes, and the diagnosis of acute SJS. Another scenario of a patient having a chronic SJS with severe dry eye and keratinization of lid margin and vascularized corneal opacity in the other eye. When you look at all these different case scenarios, what you realize is there is a common baseline to all of them, whether they are in the acute phase or in the chronic phase. And this common baseline is that of inflammation. In order to achieve a good and a normal ocular surface, what we need to do is to tackle this inflammation and hit the inflammation at its every stage of the disease process, whether it's in the acute phase or in the chronic phase, in order to have a healthy ocular surface. The most important thing is to deal with these patients in the acute phase when they present in the early phase of disease. Be very aggressive with your management protocols. It's important to be preventing any chronic complications of these disorders rather than sitting and curing them in the chronic phase. In the acute phase, whatever management you do is going to really prevent the blinding complications, especially in case of chemical injury and Stevens-Johnson syndrome. The most important therapy is topical corticosteroids in these cases. Despite having an epithelial defect, unlike our traditional learning wherein we say whenever a cornea has an epithelial defect, we really would want to refrain the patient from getting topical steroids. But in cases of chemical injury, the most important therapy is steroids, and steroids. Topical lubrications in terms like tear substitutes, especially preservative-free because they have to be given almost every half hourly to 1 hourly in these cases. Topical antibiotics as prophylaxis against mesenteric infection and cycloplegic, and topical anti-glaucoma medication as and when required. In the acute phase of Stevens-Johnson syndrome, the patient will require intensive steroid therapy with intravenous methylprednisolone with 500 to 1000 milligram in 3 doses, IV immunoglobulins, topical cyclosporin 0.5%, topical antibiotics, topical steroids, and lubrication. In the chronic phase, when you're dealing with medical management, the management is essentially to protect the ocular surface in order to support the ocular surface, to reconstruct and maintain the ocular surface. Ocular surface protection is essentially with the gamut of lubrication that are available. The preferred ones will be preservative-free lubrication. In order to protect the ocular surface, what we may have to sort on to give along with lubrication, also to give them scleral contact lens. I'll be coming in the later part of the presentation and explaining about the various types of scleral lenses. And for support of the ocular surface, we have modalities like oculoserum, or transretinoic acid, cyclosporin, oral tetracycline, topical and oral corticosteroids, and surgical therapy. Autologous essentially acts by providing a lot of surface protective agents in the form of lactoferrin, lysozyme, vitamin A, epithelial growth factors, and various other immunoglobulins which are required in order to protect the ocular surface. The important thing is to prevent the cytokine activation and also to have a tear film stabilization, which will really help you in ocular surface diseases and also improve the patient comfort level. All transretinoic acid is usually available as an ointment, not easily commercially available. It improves the conjunctival squamous metaplasia and all, but the only important thing is this leads to a lot of peripheral conjunctivitis. Cyclosporin acts by inhibiting the T-cell mediated cytokine production and in turn decreases inflammation. Cyclosporin may be given as 0.05 to 2%, 2 to 4 times a day, and a long-term therapy is required in most of these cases. Oral tetracycline also act as surface protecting agents, and they may be given over a long period, that as low doses as 20 milligrams a day to be continued for a long time, along with the antibacterial property. They also have anti-inflammatory and anti-angiogenic property. Omega-3 fatty acids along with omega-6 fatty acids have now been proved to be anti-inflammatory and which block the gene expression of the pro-inflammatory cytokines and are just protecting the ocular surface. A low dose of steroid therapy has to be maintained on a chronic phase in most of these patients in order to decrease the inflammation that they have. Notocritinol etabolate 0.2 to 0.5% may be required in most of these cases. The patient in the acute phase may be started with oral steroids as high as 1 to 1.5 milligram per kg, which have to be slowly tapered in the chronic phase, and later on the patient may be required to be maintained on a very low dose of steroids. Ocular surface reconstruction will be dealt in detail in the previous presentation and also in the next presentation by Dr. Rao. You have to maintain the ocular surface, and in that you may have to go in for a step-ladder approach to decrease the inflammation and may have to swap into immunosuppressive therapy. For very mild inflammation, you may just give the patient methotrexate or naloxone. When the inflammation increases, you may have to go a step up or a step down ladder along with this kind of a protocol. When you start with methotrexate, in case of very severe inflammation, you may also have to resort to higher immunosuppressive agents as azathioprine or mycophenolate, or sometimes even cyclophosphamide. In acute intermittent cases, you may also require to give them high pulse doses of steroids intermittently as well as intravenous cyclophosphamide whenever the patient is having acute inflammations. Especially when you're contemplating any surgeries in the acute post-operative period, also they may be required to be given pulse steroids and pulse immunosuppressive agents. There are different protocols that are for non-pemphigoid associated and pemphigoid association inflammations in these cases. So how the immunosuppressive agents work is by decreasing the inflammation at various levels in the immunological cascade. Most important thing is when you're having these patients on immunosuppressive therapy is to monitor them regularly for their enzyme levels, as liver function, the renal function. It is also important to counsel the patient about the cost factor that is required with this immunosuppressive therapy. Most of these therapies are costly. The cheapest being the methotrexate, which has to be given only once a week dosage, comes to almost only 12 rupees per week. To costlier agents such as cyclosporin, the patient has to shell out almost 200 rupees per day. Most important and the last but not least important thing is to give a psychological therapy, because these patients will require to be on a chronic follow-up with you. There is always a patient and the family counseling that is required in these cases in order to motivate them for having a regular follow-up, because these patients are going to be your patients for lifelong. Thank you. Contact lens. These are basically haptic lenses, which are a large size lens. So, compared to your normal rigid gas permeable lenses, these are fluid reservoir lenses, which are usually large size, and they rest on the sclera. They are either a fenestrated or an air ventilated or a non-fenestrated or fluid ventilated lenses. The most common prototype used as the Boston sclera lenses, which received the FDA approval in 1994. These are large lenses which are prepared and specially designed for each patient's eye. The design is basically a 3 primary curve design, which has a haptic portion, a posterior optic curve, and a posterior intermediate curve. These essentially rest on the sclera and they vault on the cornea. They have a therapeutic indication, especially by providing an adequate supply of oxygen. They also decrease the friction, that is because of the keratinized lid margin, which comes in contact with the cornea, and thus decreasing the corneal scarring and also vascularization. And also a constant aqueous interface prevents any desiccation and effect of the air, and exposure also decreases the chances of any epithelial breakdown in these patients. So basically these are fluid reservoirs which conserve moisture, they delay the keratinization, protect the abrasive damage because of the lid margin to these things. Most important thing is the fitting of these lenses. Each patient has to be fitted very differently than any other patient. Compared to a keratoconus patient, these patients require a totally different fitting parameter. They are basically a haptic bearing surface which are having a focal scleral compression, which will trigger local chemosis and leaking discomfort and rest on the sclera without making the situation worse. So in order to have a good situation with good comfort, you have to see to it that this lens is not impinging on the sclera, does not cause any conjunctival compression. It has to just snugly fit onto your ocular surface and also improve in the fluid reservoir status of the eye. Most important thing is you have to, when you're having these lenses, because these patients already have a lot of inflammation, you have to see to it that there is no scleral compression when you're fitting the patient with these kind of lenses. Also, these are available in various toricities, and also not only do they improve the ocular surface comfort, but would also help you, providing a good visual acuity, decrease the photophobia in these cases, and allow the patient to have a very normal life. Thank you.
Thank you, Jimmy.
Using a variety of techniques. But often you're faced with a cornea like this, in an eye with multiple comorbidities, in whom multiple grafts have already been done, and the immunological consequences of a subsequent graft seem terrible, and therefore you know that you can't really repeat a biological tissue transfer in this eye. So in this situation, we have 3 options. We can either use a plastic implant, we can use corneal constructs which are built up in the lab, or we can use a synthetic implant to try and serve as a corneal replacement solution. Of these 3 options, the one with the longest track record today is the keratoprosthesis, and that's what I'll be covering in the next 10 minutes. This is a slide that I borrowed from my teacher, Professor Falcinelli, and this describes his experience with what we call the biocompatible keratoprosthesis. This is one of the 2 broad designs of keratoprosthesis in the sense that it's made of a material that's biocompatible with the eye, and that's typically PMMA. And we've had various designs, and you can see that my prof's experience started in the early 1960s. And the Cardona and the Choice implants, and the survival of these implants was not particularly good even in his hands. The second type of keratoprosthesis that we can use is something that's called the bio-integrated, wherein the material of the keratoprosthesis tries to integrate itself with the tissues of the eye. And again, we've had various designs over the years, the Lacombe, the Pintucci, and the Kyrilla. And unfortunately, most of these have fallen out of favor and are not much in use today. In India, early keratoprosthesis work was and is still being done in Amritsar by Dr. Daljit and Dr. Hindu Singh. This is their design, a champagne cork PMMA implant, which is put into the cornea through an opening either in the center or in the limbal region. And it stays in place because of the strength of the steel sutures that are used to anchor it to the eye walls. And those blue lines are the steel sutures that go into the sclera right at the equator. Now this has worked fairly well, but there have been some problems because it's not necessarily an integrated approach, and the opening in the cornea through which the plastic cylinder sits is often the seat of problems as time passes on. Another attempt to do the same thing, and the one that's enjoying wide popularity now, is the Dolman design, which is a nut and bolt hypothesis. And basically this is not an integrated keratoprosthesis, we call it a biocompatible keratoprosthesis, and it consists of these various parts. There's an optical cylinder on the top, there's a corneal graft in the middle, there's a base plate at the bottom, and this whole complex is locked in place by a titanium locking ring. So if you look at this composite drawing, you punch a central 3 mm opening in the corneal graft, which can be of poor quality. You place the optical part upside down, and then you place the graft through the strut in the optical part so that the opening goes through that. You take the base plate and fit it onto the strut, and then you put the titanium ring to lock the whole composite in place, and then you take this and sew it onto the eye just like you would with any typical corneal graft, and therefore it's not very difficult to do for a corneal surgeon. And then the whole thing is covered by a contact lens, and now we can do this through the lid as well in an extremely dry eye. So this is how it looks after you put it in place, and that's the air bubble between the surface and the contact lens that's protecting the composite structure. So if you look at the results, this is a recent publication of the international experience with the Boston Type 1 K-Pro, the one that's on the surface. 113 Type 1 K-Pros were implanted in 11 centers. 60% of these eyes had ambulatory vision 2 years after surgery, and about 80% had a retention at about a follow-up of a little over a year. There were some complications, retroprosthetic membranes being the most common in over a quarter of these eyes, sterile corneal necrosis in about 20%, and infectious endophthalmitis in about 10%. So these are the two designs that we have today. The one on your left is the one that goes on the surface, the Type 1, the one that's used most commonly. And the second one is intended for use in dry eyes so that the strut can go through the lid. This is the Type 2 design. It was originally introduced, fell out of favor, but now with the popularity of the Type 1, we're trying to expand the indications for use of this design, and therefore the Type 2 is slowly making a reappearance. However, if you saw an eye such as this, and we've dealt with this in the previous talks as well, it's unlikely that either the Type 1 or the Type 2 will really do a good job. And in this kind of a bone dry eye with significant ocular surface destruction where the lids are virtually stuck to the globe, the only other procedure that we can use is something that I show you now. And this is a situation where you have significant ocular surface damage as well, where the lids have been really hurt. And so the Type 1 K-Pro, even if the eye is moderately wet, cannot be used because it needs a normal and healthy ocular surface and lid structure. So in these kind of eyes, to help the patient such as that you saw in the previous slide to return to his normal life and functioning, we use another technique. And here this is a patient who's returned back to his normal activities after the surgery. He's able to read and write, and this is somebody from China whom we operated about 7 years ago. He has a limited visual field of about 30 degrees, but he is reasonably ambulant, as you can see. And the reason why he can do all this is because of this little cylinder that's nestled in his left eye. And you can see the bulky appearance of the eye, and this is because we've integrated the cylinder to the tissues of the eye using a tooth as a carrier. So if we ask why the tooth, it is because it has certain properties that are critical to the surgery. It's a firm tissue, it can regenerate, it can integrate with the soft tissues, and we know that because it works well with the mucosa in the mouth, and because there's 32 of them, we can remove it from the mouth of the patient to reconstruct the eye. And this is the surgery that we call the osteo-odontokeratoprosthesis, essentially meaning we're using a bone and tooth composite as a corneal replacement structure. As with most keratoprosthesis, and particularly with the MOOKP or the modified OOKP, we must remember that this is a corneal replacement solution, and therefore we can only do this when the rest of the eye is entirely healthy. It is a fairly morbid surgery. It takes a lot of effort on the part of the surgeon and the patient, and therefore we only offer it to people who have severe bilateral visual impairment and are essentially non-ambulant. There are multiple considerations. There can be significant complications both intra and post-operatively, and while most of these patients can see 6/6 if the surgery goes well, they have a limitation of field which is about 30 degrees. There is an altered cosmetic appearance as you saw in the slide before, and they do need a lifelong follow-up, which means there is a need for mental adjustment on the part of both the patient and the surgeon. The indications would be anything that damages the ocular surface to the degree that we saw earlier, where there's just a dry dermalized surface, so it could be from any of these conditions. And when choosing your patients, it's quite important to make sure that they don't have any bleeding diatheses or blood thinners, uncontrolled systemic hypertension or significant electrolyte imbalances, or a compromised circulatory state. We perform tests that help us look at the anterior and posterior segment. We measure the axial length because we can customize the cylinder to the length of the eye. And it's quite important to pay attention to the microbiology of these surfaces because quite often they can be infected as well. And this is something that the eye surgeon must get used to doing. It's not something that we normally do. We need to look into the mouth of our patients for this surgery. We look for the presence of the teeth and the health of the gingiva and also the cheek mucosal status. And we must learn to look at dental radiology and exams. So these are my mentors for the procedure and my grateful thanks to them. On your right is Professor Falcinelli and on your left is his son Johnny. And they are the ones who helped us bring this procedure to India and they still mentor us in this. Now what is really different about this particular surgery is the osteodental lamina or the ODL, and this is something that we don't see generally as eye surgeons. So we extract a canine tooth, and this is a monocusped tooth, and it's got the longest root, and that's why we choose it. There are 4 of them, 2 in the upper and 2 in the lower lid, and here we've taken it from the maxilla. So we don't extract it like the dentist does. We don't hold the crown and yank it out. We actually cut it out with the surrounding bone, as you see there. And then we fashion it into a lamina which is about 3 to 4 millimeters in thickness and about 15 to 13 millimeters in dimensions in a rectangular manner. This is a hole that's being drilled at the dentine, and we cement this little plastic optical cylinder with dental cement. And if you look at this cartoon, this is how the cylinder will look. It has a short stubby posterior part, and that's the one that sits in the anterior chamber through an opening in the cornea. And the whole composite is covered by a cheek mucosal graft to protect it. Now this is a 6-hour procedure at the best of times, and I've just compressed it into 8 little vignettes. To extract the tooth, create the osteodental lamina. In the eye, you remove all the scarred pannus. We take a large cheek mucosal flap, and that is put over the exposed ocular surface. And this is a little cheek subcutaneous pocket with antibiotic powder into which you put the osteodental lamina. We come back 3 months later, we reflect the mucosal flap from the eye, remove the osteodental lamina from its resting place, and it has a connective tissue covering now. We make an opening in the cornea, extract the entire iris by its root, we get an ICCE done, and then an anterior and mid vitrectomy, place the lamina in place and suture it to the episcleral tissues. The mucosa is wrapped back and you make a hole in the mucosa so the cylinder can come out. This is an example of some of the eyes that we work with in the osteoodontokeratoprosthesis surgery, and this is an example of a post-operative appearances that you will get, and you can place this implant through the lid as well. We can use the spiral CT to assess the position and the health of the lamina to see whether there is any attrition or resorption of the bone, and this is basically the results that we've had. This is about 41 procedures done over the last decade. The retention rate is about 95% over the follow-up period, and the functional success is about 70%. And a lot of these eyes I can actually see 6.6 and 6.9. But there are significant challenges to the keratoprosthesis surgery. We still don't have a good option or solution for children. There is the issue of cost, particularly with these long surgeries that we do. Patient has to come back for follow-up for lifelong. We are having problems with long-term retention no matter the technique that we use. And some procedures like the OOKP do cause ocular changes and an altered cosmetic appearance, and we need to work on improving that and reducing the complications as well. So before I quit, just like to invite you all to the next meeting of the Cornea Society, the CARACON 2014. It's going to be held in my city in Chennai, in Mahabalipuram, a beach resort. We will be discussing most of these issues in that meeting as well. So all of you are welcome. Thank you very much.